So this is where I have to use technology, talk, and hold a microphone all at the same time, which, might work. The first thing I'm going to say is a caveat that I am not a specialist in health tech, but I've got 20 years of experience of working with people around health inequalities, both as a youth worker on the ground, as a practitioner, and as a public health specialist, commissioning services for vulnerable populations, and now as head of improving population health of the ICB, looking at how we can work together as a partnership across West Yorkshire to improve the whole of the system for people. So I'm just going to start by saying, well, thank you for inviting me to talk today. I think Dawn dropped me in it, actually, so thank you, Dawn. This is a really important topic, and obviously the changes in technology have a massive impact on health and healthcare services, but they also have a massive impact on health inequalities, both in alleviating and responding to health inequalities in various different ways, but also the caveat that they can actually widen health inequalities, and how do we manage and engage what we're doing isn't going to do that. So we need to ensure that whatever we're doing is implemented equitably and that it doesn't widen the existing inequalities gap. And as Pad says, obviously we've all lived through a pandemic, which we've seen. What it did is it raised the awareness that health inequalities exist. They've always existed and they've always been vast. And 45% of all the inequalities in West Yorkshire are in Bradford. So when you think about the disparity of the inequalities themselves, it's huge across our system. And actually what the pandemic did was open a door to say we need to do more, and it needs to stay on everybody's agenda, because what happens is public health likes to do things in fits and spurts, and all of a sudden public health will think health inequalities is a great thing, and then all of a sudden prevention will be a great thing, and then all of a sudden something else. And actually it's not. It should be something that's core and fundamental to everything that we do. So I'm going to give you an overview during the presentation around, and please tell me if I'm going on because I can talk a lot. I'm going to give you an overview of the work that we do across West Yorkshire, but I'm also then going to try and link that to how health tech can support it, and how some of the work we're doing across the ICB, not just in my programme, but across our programmes, are already linking this. So the current landscape is that we've got vast inequalities and significant inequalities across West Yorkshire. And the majority of that's not caused by access to healthcare. The majority of that is caused by socioeconomic circumstances that people live in. 80% of what happens to us is out in the community. Only 20% of what happens to us can be fixed in a health and care setting. And that's really important, because that's housing, that's jobs, that's the green spaces that we have access to, all of that causes and widens and makes things that happen to people, chronic conditions, long-term conditions, disproportionate. So what we have access to, both in our communities and around us, socially, economically, is just as important as accessing healthcare. So we have lots of different initiatives in the Improving Population Health programme to try and address this. And it means looking at health across the whole life course, holistically, across that parity between physical and mental health. And it's also about putting a trauma-informed lens on everything that we do. And that's really important, and I'll explain more about that in a minute. Our approach is to look at the determinants of health. So we have a post that sits between the West Yorkshire Combined Authority and the Improving Population Health programme. And her key role is to look at those determinants of health and how they impact. We have a climate change programme, we have a suicide prevention programme, and we have a massive health inequalities programme. And we link in very closely with housing colleagues so that we can look at housing and inequalities in housing. And what we're trying to do is build that integrated partnership and collaboration across the system to support healthy behaviours. Now, I say that with a caveat, because when we start talking about healthy behaviours, we get into that individualistic blame. And actually, a lot of what happens to people and a lot of what they do isn't through choice. It's through those health inequalities and things that have happened to them. But we do need to look at health behaviours and protective factors and encourage that early intervention to reduce inequalities and improve outcomes for our population. Core 20+5 is one of the ways in which we do this. So we get funding from NHS England to work with our 20% most deprived. We often look at the 10%, because when you look at 20% across West Yorkshire, you're talking about almost all the population. So actually we often go down even further. And it's looking at specific clinical areas as well, around mental health, respiratory, cardiac, children and young people, and maternity. But it's also looking at those people, those population groups that are most vulnerable in our community, our inclusive health groups. It's called PLUS on this diagram, which is a lovely way of describing it. I keep looking at you because it's NHS England, sorry. But it is our health inclusion groups. It's people that are vulnerable, that have, they might be homeless. It's our adults with mental health, alcohol, drug issues. It's our prison population, people in touch with the justice system. And it's people who are migrants, refugees and asylum seekers. And the inequalities they face are even more entrenched than the inequalities in the general population. Not that we're counting and, comparing, but actually there is a proportion of our population where we need to do more. And one of the reasons we need to do that is because trauma and adversity is a cause and a correlation with health inequalities. We cannot respond to health inequalities if we do not respond to trauma and adversity. This is one of the biggest unmet public health needs of our time. So we've got a programme across West Yorkshire trying to ensure that we are trauma-informed and responsive by 2030. Every sector, every organisation, every member of the workforce and our population. And it starts with the workforce. It starts with the people who care for the people, because if they're not cared for, they can't do their job well. And we're doing that across every sector. And in order to do that, we've done some targeted work with our Core 20+5, and we've got some trauma-informed prison officers across the system in HMP Leeds and Wealdstone. We're doing lots of work with the police, with housing, etc., to try and understand what's happened to people that's put them on that trajectory to poor health outcomes. And within that, we're also utilising tech. We're utilising virtual reality to train our workforce. We're using AI. And we've got a whole plethora of resources that are digitally accessible for our workforce to be able to get things at their fingertips. One of the big things, though, that we're doing in that programme is around digital trauma. And that's around looking at the harm that digital, tech and social media can cause. And we're working with a digital trauma specialist in the district, Kath Nibbs, and she's based in Wakefield. And she's actually developing a digital harms strategy for us for West Yorkshire. The other thing that we've got is our health inclusion unit, and this is very much bringing together our partners across all places. So every place has their own inclusion health work. And we're bringing those partners together to look at what we can do once, what we can do collaboratively to help these groups. We're the first ICB to be an ICS of sanctuary, which means we are welcoming and looking at the health needs of refugees, migrants and asylum seekers. And when you think about that population group, they've got trauma from where they've come from and why they've had to leave their country. They've got the trauma of travelling across to the country that they end up in. And then they've got the trauma of living in a new country and culture. And that's immense. So the work that we do in that area is really important. And we're also doing work around connecting inclusion health and Core 20+5 around gypsies and travellers and around maternity for asylum seekers and refugees. So this is a huge piece of work that's going to be responding to inequalities through that collaborative, intelligence-driven data that we have, particularly for those groups that are most vulnerable to exclusion. And then we've got the Academy. This is one of our flagships of the programme. So our Health Inequalities Academy is about increasing capability, capacity and intelligence in the system. And it's very much focused on how do we ensure that everybody understands what health inequalities are, and how do we provide the tools and support and the resources for people to go and respond to those inequalities. We've done that through a fellowship programme. It's in its third year. We're seeing people coming through into jobs because they've done the fellowship programme. And that means people working with us for a year, 1 day a week, and we give them public health training and we give them adversity trauma resilience training and various other training through the Health Inequalities Academy in order to raise awareness and bring together those organisations and professionals that can learn, share and implement then the strategies that will help reduce inequalities across the system. So how do we link this to technology? How am I doing? Am I doing all right? Fab. So there's many different ways we can link health inequalities and technology, and it's got a massive power to increase access and improve outcomes for our population through all the things that you can see on the slide, and I'll go into them in a little bit more detail. But as I said before, it's really crucial that we close that digital divide and that we work with people that are fearful of health tech, the amount of people, particularly older people, that don't want remote appointments with their GPs because actually they want to sit in a room with their GP and talk to them. Or are afraid to leave their homes and therefore digital tech is going to be really beneficial for them. So what we need to do is really understand how we do this well and not widen that inequalities gap. So one of the things that we need to do is look at enhancing health literacy through technology. So one of the things that's really easy to navigate a health system actually it's not. I was going to say it's really easy to navigate a health system if you work in it, but it's still difficult. And I work in it every day. And so for people who don't, and people who don't have access to the knowledge and the intelligence and health literacy, I find that even harder. And then when you combine that with digital tech and access, that doubles the barrier. So we need to work with people around health literacy, but digital health literacy as well, and provide those tools and interventions that can help those population groups understand what this is about and not be fearful of it, and see it as a bonus. And many of them will be doing it and not knowing. You know, we all have apps on our phones, don't we, around MyFitnessPal and this, that, and the other. And we encourage the use of those things where people find it comfortable. But interestingly, we did do a survey a few years ago with children and young people who said they don't want to access healthcare on their phone because that's for fun and pleasure. And so I don't want to deal with my health on my phone. So it's really important that you know your audience, and that's what we find within health inequalities. It's not one size fits all. And then improving access, there's many different ways in which we can improve access, through remote appointments, through looking at people that have faced challenges around mobility, around transportation, and like I said before, people that live in those communities where they feel unsafe to leave. And I'm the serious violence lead for West Yorkshire ICB as well, and we see that a lot. We see people not wanting to leave their homes because they've got fear of safety, even walking through the streets of their own communities. So actually for those people, they might not be going out and accessing healthcare. So the digital world would be really helpful for them. Obviously, AI I use it all the time. I love it. ChatGPT, it really saves some time. It's fantastic. But we need to be wary of that too, because what we're seeing is, particularly in the workforce, a lot of applications coming through that we can see have been ChatGPT'd. But actually, there's a double-edged sword there, isn't there? Because so many people where English isn't their first language struggle to get through an application process because they can't write in the way that people who are reading them, like me, want to see questions and answers written. So actually, the use of AI for things like that in our workforce and empowering people that English isn't their first language, will help them maybe get through some of those barriers to recruitment. So the Health Inequalities Academy is looking at tools like this, how we support our at-risk populations, but also how do we deliver those tailored interventions and use health tech and AI to really understand what those interventions might be. And personalised care is one of the biggest examples of that. If we use AI, we can put in so much information about people that it can generate personalised care plans. It can generate ideas on how we can best meet the needs of those groups with professional and clinical oversight. So I think it's really important that we combine digital tech with the expertise that we've already got in the system. This isn't about replacing people and replacing the human value of those interactions, but it's about enhancing them. I've mentioned about the digital divide, so I'm not going to go into great detail, but it really is important that when we're looking at low-income families that might not have access to the internet, or we're looking at people that are just scared of using the internet, going, my father-in-law will not touch, he'll go on the internet with every single security measure enabled. He won't touch social media, and if we even suggest to him that he would do an appointment online, I think it would do him in, to be honest. So, there is groups out there that need that additional support. And that's where the community comes in and where our partners come in, because we don't have the expertise and the capacity to necessarily do that. But working with you guys, we can make things easier and more accessible. And I think one of the really important areas is empowering the workforce and using digital tech to empower the workforce. I've already mentioned how we're using virtual reality with police officers, actually, around trauma and adversity, and them seeing what happens when they're arresting young people and throwing them in the back of a police van, etc., etc. And so there are some tools that are out there that I think are really beneficial with those that can give permission and can give consent and are adults. Obviously, we had some projects that wanted to use them with young people, and we're like, no, we will re-traumatise them. Never mind the fact that putting big helmets on their heads is not necessarily a very healthy thing to do. And then looking at how, and I mentioned this, how we can tailor our support to people by using some of the digital tools that we've got. We do use DigiBeat across the ICB, and there's various other digital health tech that's embedded. And I guess what we want to do in the Improving Population Health programme is put as many options out there for people as possible, have a variety of access, work with you as experts, get you involved in our Health Inequalities Academy, our trauma-informed programme, so that when we are doing this, we are doing it in a safe, trauma-informed way, and that we can give people the access without widening those inequalities. So that would be our vision, I guess, for the future. Oh, and also it helps with multilingual tools. Must have put this on and not realised. But obviously, you know, language is a barrier. And if we've got ways in which we can use it, and we were having this conversation actually, because I'm doing some trauma-informed training with Lloyds Bank, and they have a real issue with translation services, and their translation services are all app-based. But for people who can't read, and they can't read their own language, but they can speak it, that's still not accessible. So actually, when we're thinking about these, it's those tiny nuances that we think, oh, this is fantastic, we've got this app and it's going to help us talk to people, and actually it's not, and it's creating even more frustration and barriers. So the vision is for a more healthier, equitable future for our population across West Yorkshire. And that's not about people living longer in poor health. We don't want that, nobody wants that. It's about people living longer in quality health, with quality of life, and doing the things that they choose and want to do. And that's ultimately our goal. And we can only do that if we look at intervening earlier, mitigating harm where harm's caused, reducing that inequalities gap, and doing all that through a trauma-informed, compassionate lens. And that's us, that's what we do. Thank you.